Okay, thank you. Thanks for asking me to speak about these three topics. It's going to be a whirlwind. Um, the most important topic is first. It's also the shortest one, but it's the one where I think we in the acute care and rehab facilities have the maybe opportunity to make the most difference. Um, so we'll get started right away. I'm going to give objectives three times throughout the talk so that we kind of stay organized. Um, and it's not too much all at once. So I'm going to just review the scope of the problem, patient risk factors, the diagnosis, and how we go about preventing DVT. So I'm going to start with a case in each of these three topics. Um, this is a healthy 32-year-old man who's on unit 58 for rehab. He has an incomplete spinal cord injury. He has paraplegia. And this is just a very quick overview of his presentation. So we were just doing a simple kind of bedside round on a Monday morning, and he just mentioned in an offhand sort of way that he had new pleuritic chest discomfort and a bit of a cough over the weekend. He didn't have any abnormalities of his O2 sats, and he wasn't really distressed. Kind of just mentioned it almost in passing. And then we did do a CTP, and I see that maybe this version of the talk, as things would happen, doesn't have the findings, but there were findings that were consistent with PE. And so we initiated treatment dose anticoagulation. So this was a combination of nursing staff noticing his symptoms and he mentioning it in the medical rounds being done on a regular basis to identify these symptoms. So the incidence in our population of spinal cord injury is 40 to 70%, clearly varying depending on the resource you use and also the timing, since things have improved somewhat over time. So if you're on anticoagulation, the incidence is still quite high at about 7%, so we can never really let down our guard. So sometimes there isn't a lot of morbidity or mortality. So there can be just small asymptomatic thrombi, but it can range all the way up to a massive fatal PE. And 35% of acute deaths in SCI are still believed to be due to VTE. And the risk of death, fortunately, due to PE is declining. So it's the sixth cause of death in the first year after SCI. It was the second to third cause. 10 to 20 years ago, but that has improved. And then we can't forget about our population who live with spinal cord injury for years. This can be an issue creating pulmonary hypertension and progressive respiratory failure. And just an interesting statistic that those who have acute SCI and then survive the first year, the risk of death due to PE is 210 times greater than that of a similar healthy population. So it remains high. And just an interesting little clinical story. I had a younger female with chronic spinal cord injury that I was following in my clinic. She would have fluctuating dyspnea. And after the first time, which was we kind of all kind of gathered around and tried to make sure she was okay and gave her anticoagulation, she would actually present yearly and say, "Oh yeah, I had a little bit of shortness of breath," and I called Dr. Rimmer, the respirologist, and restarted my anticoagulation. So she was continually experiencing recurrent PE and just needed to have that connection. So it is a real problem that's still happening. So some of the common risk factors reported in the literature include a lower spinal cord injury, paraplegia, complete injuries, um, coexistent skeletal fractures, older age at the time of hospitalization. Uh, they're more common sooner after injury if the patient has had a prior DVT or if they had absent or delayed thromboprophylaxis. So the clinical presentation, not to forget that both clots in the legs and in the lungs can be silent. So for DVT, patients might report, or staff, new swelling in the leg or legs, pain, erythema of the calf, tenderness, and potentially fever. For PE, dyspnea, pleuritic chest pain, decreased O2 sats, again, fever, tachycardia, and of course, a severe presentation, code blue, and even death. So despite how common they are, the literature discourages routine ultrasound done on everybody at different transitions throughout their acute care stay. So just if you have symptoms, we do order ultrasounds on the legs because there is a pretty high incidence of PE if a DVT is diagnosed, of about 10%. So if the patient does have symptoms at the bedside, just in the legs, we would do an ultrasound, and we would want to confirm the source of the VTE in a patient who happens to be diagnosed first with a PE. So we go back and ultrasound their legs just to look to see if that's where the clot came from, so as to not look elsewhere. And then for PE, we would also do blood gases, ECG, and CTPE, which includes a pulmonary angiogram, to rule out PE. So for prophylaxis, which is something that physiatry is very keen about checking when we do our consults, it says in the consortium, we recommend that mechanical thromboprophylaxis with intermittent pneumatic compression devices, with or without graduated compression stockings or TEDs, be applied as soon as feasible after acute spinal cord injury when not contraindicated by lower extremity injury. I do see this as pretty routinely done. Sometimes I do actually step in to say, okay, it's been more than 2 weeks. We can likely do away with the intermittent pneumatic compression devices, which sometimes bother patients or just add to the care burden. So those are both on initially. Then moving on to the choice of heparin, it should be low molecular weight. We have different patterns across the country of what choice of heparin, but they are equally effective, enoxaparin and dalteparin, in studies. And then the duration has also been discussed over the years. So it is now phrased as 8 weeks or until discharge from inpatient rehab. And then we would reinitiate their prophylaxis for VTE if you are rehospitalized throughout your lifespan, just as would be generally the case with an able-bodied person without a spinal cord injury. So I think that is the end of VTE. So if you do have any questions, just pop them into the chat, and hopefully we have time to get to them later. So now we're going to move on to our second topic. And so what I want to do with this topic is to work on a definition. Some of you may not be familiar with syringomyelia, so we're going to try to just fill in those gaps. I want to review presenting symptoms and signs of post-traumatic syringomyelia. We want to provide an overview of the pathophysiology and discuss treatment. All right, so I'd like to start with a case. Oh no, definition first. So syringomyelia is a post-traumatic development of a CSF-filled cavity or cyst within the spinal cord, or we could call that within the central canal. This is a diagnosis, syringomyelia, that actually is found in other populations as well, not only in post-traumatic, but is something that we're going to approach from a post-traumatic perspective today. So I have a case here that of a lady I met earlier in my practice, my outpatient clinic. So she had had a high thoracic around T3 spinal cord tumor that was a benign tumor, resected in India in 1999. And then she came to Canada and she was seen in 2005 in my clinic. And we kind of started from scratch to sort of address all of her issues related to her paraplegia. She did have some common issues. Severe neuropathic pain. She had neurogenic bowel and bladder, a sacral pressure ulcer, and then osteoporosis, just to name a few of her main issues. And just as encouragement to all the healthcare providers, it's interesting that even when you see patients in your clinics that have had their injuries for 5, 10, or even 20 years, and people are used to doing things a certain way. I think this lady was happy with her bowel routine once a week. Lots of people are willing to make some changes with some gentle education and suggestions to help limit complications going forward. So try to make sure that all of your patients are connected with an outpatient clinic for that reason. In her case, what we did is a baseline physical exam. She had a sensory level that's not surprising at about T2. Her strength was normal in the upper extremities, and she had no strength in her lower extremities, but she did have digital rectal sensation. And so her diagnosis is ASIA B or AISB T2 paraplegia. So one of her main issues that prompted me to order imaging was how severe her pain was. And so I ordered an MRI. I think initially that maybe her tumor is back, even though, there was no evidence of a change in function or in her exam, from what she could tell me. So this is her MRI. And so the cord is this small gray ring squished to the sides, and this central cavity is actually the fluid from the CSF and her syrinx. So it's what would be considered massive, and it also extends very, very high, all the way up to the brainstem. And here she is sitting there talking to me and breathing normally. So that was quite shocking. Here you can see right along the edges is her spinal cord, and in the middle is a large syrinx. So I actually saw this when I was reviewing for this talk, that this has been reported, huge, almost asymptomatic syrinxes. A lot of them have some of the symptoms we're about to discuss. This lady didn't have too many of those other than perhaps her pain. So I quickly got a neurosurgery opinion. I did re-examine her. I did quote in my or state in my notes that she didn't have a change in her sensory level. There was no new weakness. There was some perhaps pain in her shoulders, perhaps affecting her deltoid strength, but her Asia muscles were still strong. I did think that she had a little bit of increased tone. I don't know if that was there to begin with and I missed it, or if um, if it was a new finding actually. And then her upper extremity deep tendon reflexes were mildly brisk, at the 3+ range. So I did ask for neurosurgery to see her, and then they ordered an MRI within a year, after the first one. And since that was stable and didn't show any deterioration, they just told me to follow her symptomatically. And then, in fact, at some point, she produced films that were done closer to the time of her surgery, and the syrinx had actually started way back then and hadn't really gotten worse. Unfortunately, her pain did persist, but her neurological exam of strength and sensation remained normal, with the ongoing increase in deep tendon reflexes and slight increase in upper extremity tone. So to try to get a handle of on this, I'm going to give you some facts about syringomyelia. So this is a presentation that doesn't always result in symptoms, and there usually is a small cavity right at the location of the spinal cord injury that doesn't always progress to become a larger cyst. So generally, we're talking about a cyst that takes up 2 or more vertebral segments. And so symptomatic syringomyelia can occur in up to 10% of patients, but more common, I guess, longer term after spinal cord injury. So the median onset is 9 to 15 years after spinal cord injury, but it can be quite soon, as soon as 1 month, and as late as 45 years. I did have another patient that had a lot of tingling in his hand. He was a paraplegic as well, and that was just in his inpatient stay, and he was found to have a syrinx as well that needed to be followed. And then we have another patient right now in the acute care that has a syrinx, and he was just discharged from Unit 58 last fall. So these things still do crop up, but I haven't seen a lot of them over my career. The significant syrinxes are more common in complete injuries, male, which is thought to be because they might tend to be involved in higher speed or more intense injuries. Syrinxes are usually similarly prevalent in thoracic and cervical lesions. And then they're felt to be more common if there wasn't a significant decompression done, which perhaps might have been the case when I was training, but now we are usually seeing that patients have a decompression initially. And then again, if there's a higher speed injury or higher force injury, there will be a fracture and a dislocation and more disruption at the site of injury, and that would be a risk factor as well. If there's spinal canal stenosis, post-traumatic kyphosis, so a skeletal deformity, or a history of prior spinal surgeries, these are also believed to be risk factors. So in terms of your presenting symptoms, so there's something called a suspended sensory loss that is classic, and that is when there is a primarily sensation loss in a cape-like distribution, which is from the involvement of the cervical dermatomes, and also dissociated sensory loss. So I'll show later why we get a loss of pain and temperature sensation, but preservation of the sensory modalities that go through the dorsal column, which are vibration and position sense. Segmental weakness following, of course, whatever is the new involvement, the new levels of involvement based on the myotomes, and then classically burning pain. There are a lot of nonspecific symptoms. So worsening spasticity, worsening or change in bowel and bladder function, new unexplained AD, and worsening neuropathic pain. Obviously, when patients present with these, there are many things on each of these areas where we would have a differential diagnosis, and one of them would be a syrinx. But there are some symptoms that are a bit more specific for perhaps leading us to think about syrinx, and that would be pain that increases with coughing or straining, perhaps radicular pain if the patient is able to identify that much, that specific location of pain. The new ascending sensory symptoms. So is this person losing sensation and they have a new neurological level? Excessive sweating above the injury, while uncommon, would be another cause, potentially for a syrinx because of involvement of the autonomic fibers. And in terms of ascending sensory symptoms, one of the other things to watch out for is just something more simple, like a focal neuropathy, such as carpal tunnel syndrome, which can cause new tingling or new numbness. So here's a beautiful picture that I obtained from looking around, where we see that there's a spinal thalamic tract here, which is kind of an anterior lateral aspect, but the tract that carries on up the mostly lateral aspect of the spinal cord actually receives fibers from the other side of the body, which cross or decussate through or close to the middle of the cord. So if you have a cavity that's enlarging in the center of the cord, you'll see how these fibers for pain and temperature would be damaged potentially. And then on the other hand, the fiber, here's a sensory incoming input, the sensory information that goes up the dorsal column, sorry, actually stays fairly far back, posterior in the cord and not close to that central cavity. And again, we see here the spinal thalamic input, pain and temperature, crosses over, gets pushed aside or damaged by the expanding syrinx, and then that's why the patient would have a change in pain and loss of pinprick sensitivity in that distribution. When it comes to weakness, so new motor weakness, it's a later finding because the fibers that are involved in motor information going down the cord are also to the outsides of the cord, and they don't cross until close in the medulla in the brainstem. So if the syrinx is large, it'll push on these fibers down in the cord here, but they're a little bit safer than the sensory fibers that actually cross right in the middle. If the syrinx, in the case of our patient, is causing damage up in the brainstem, then the patient might report dysphagia, tongue weakness, atrophy, facial pain, or sensory loss. And then I have seen some patients with MSK issues, so Charcot joints that crop up, say, in the shoulder of a paraplegic individual. So that can happen because of a denervated joint, and that can happen in the shoulder, elbow, wrist, and I've seen it in the spine as well. Progressive neurogenic scoliosis can also happen due to syrinxes. So again, just before we move on, the main concern here is loss of function, and secondarily, all the symptoms that go with it that could be very difficult for people, and especially the pain. So how does this happen? Hopefully we have a little time, probably have to skim over some of this, but the CSF in your body, in your spinal column, pulsates synchronously with pulse and respiration. So when the pulsations encounter the partial obstruction, are usually believed to be from the scarring around the spinal cord injury, it becomes easier for that CSF to enter into the spinal cord than to travel along its surface and stay on the outside of it. So you get this transparenchymal migration of CSF into the cord because there's been focal injury in the cord tissue, myelomalacia and scar. This is a schematic just showing how we've tried to imagine the physics of how a syrinx, which is fluid in the cord, becomes a problem. I'm going to leave it at that because some of it's theory. We don't 100% understand why syrinxes develop. But we have some suggestions later that reflect some of this conceptualization. In terms of how this changes over time, most progress. Unfortunately, a few resolve, 50% or more, can be stable for 10 years. So that's why a lot of people will follow them. And if they're not developing neurological decline, they may not receive any further intervention. There's some conservative advice that we would like to advise patients generally. And so what we want to tell them is to avoid straining, anything that includes breath holding, weights in the gym, try to lighten those. Obviously, check on how the bowel routine is going. We're also asking patients to avoid flexing their neck and to sleep with their head slightly elevated. There's a medication that can reduce the amount of CSF that sometimes helps with Syrinx symptoms. I don't know if it has been shown to change the evolution of the Syrinx. There are some surgical indications, of course, severe pain and progressive neurological decline. Um, and then the options surgically, since I'm not a surgeon, I tried to not overstep my area of expertise here, but generally they want to decompress. So resect the scar, improve the likelihood that CSF stays on the outside of the cord, and then they can shunt from within the syrinx or from in this subarachnoid space to other locations. So sometimes it's a combination, decompression and shunting. Before I move on, there's one more thing, just in terms of surgeries. It can be a very challenging diagnosis, and sometimes patients progress anyway. And in fact, that's not rare. And the surgery itself can be complicated. There can be shunt complications. So it really is a serious diagnosis. I did manage one patient that developed syringomyelia after a very slight, primarily vertebral column injury that he suffered from a car accident in his 30s when he fell asleep at the wheel. 3 years later, he presented with upper extremity symptoms, and he was found to have a syrinx. And really, his course looked a lot like primary progressive MS, because no matter what the surgeons could do, his condition just continued to deteriorate. So he did come to Unit 58, and we tried to optimize everything at the time. And then I don't know what, sort of how things went from there, but it can be a really serious problem. So we're trying to basically improve our understanding of this and then use help from our surgical colleagues to minimize the complications. So our last topic, probably fairly quickly, is HO, heterotopic ossification, going through the usual things, definitions, pathophysiology, clinical manifestations, and then how do we approach this problem. I'm going to zip through this presentation. Person with tetraplegia from January 2012 is the date of his injury. He developed stiffness during Unit 58 rehab. He had some elevation of his blood work, not severe, but a little bit abnormal. And then his X-ray and bone scan were already positive at that point. We did start bisphosphonates and continued him on what was used then, etidronate, for 6 months. He felt his hip stiffness was getting worse, so we gave him some more. And I have some imaging from him. This is initially April 2012, 3 months post-injury. And then here is what it looks like, even despite his etidronate. So not sure if the etidronate really made any difference. And I can't remember if he felt that it did, which is part of the problem with this condition as well, that it's hard to treat. So what is it? So HO, heterotopic ossification, is a formation of mature lamellar periarticular bone in soft tissue sites where it is not normally present. In this case, around the joint. But we have other basically diagnoses and names for it: myositis ossificans, ectopic bone, paraosteoarthropathy, neurogenic ossifying fibromyopathy. It's been around for a while. So we know that this is a condition that can happen in our population, but not only in ours. So we have traumatic brain injury, and actually after total hip arthroplasty, it seems to be common. After stroke, it can happen. After burns, just general fractures. So in terms of epidemiology, high rates are reported, up to 50%, TBI, really large range. But clinically significant HO is really more in the range of 10 to 20%, which honestly I think is a little high for my experience. Perhaps I'd be going 5 to 10% of all patients at the most in terms of my experience. It is about 20% prevalent in those with total hips done, and then burns a little bit lower percentage. So in terms of time course, it actually appears pretty early, 1 to 3 months post-injury. And then we've seen 20 days and as late as 1 year. So it's a little bit more of an earlier phenomenon to be aware of. Once it starts, kind of takes a while for it to come to a point where it's done growing and it's mature and it's hardened up and is real bone. So 12 to 18 months generally. Risk factors in spinal cord injury, more spasticity, complete injuries, other problems, specifically pressure sores, UTI, and pneumonia. So all on the kind of infection side of things, inflammation side, and then older age. Sometimes the residents are asked what joints are involved. Usually they have to be generally below the level of injury. So, but hips are most common in both diagnoses. Um, and then how does it happen? Why does bone start to develop? Well, not entirely clear, but there are osteoinductive factors that stimulate differentiation of typical soft tissue, mesenchymal tissue cells, unfortunately into osteoblasts. Beautiful chart for you to review later. But we have the mesenchymal cells, they differentiate, become osteoblasts. Then there's alk-Phos, which goes up. You can see that in your labs. And something called tropocollagen becomes collagen. And then we have proteins and other things forming the matrix, calcium precipitates, and mineralization. This chart doesn't really explain why, and there, like I said, many postulated theories, but it does explain that it comes initially from this tissue cell differentiation into osteoblasts. So the most common presentation is painless loss of range of motion on routine exam or during therapies, stretching. So the therapist will tell us during rounds, the hip is getting tighter. Sometimes it's painful. There can be tissue swelling, fever, and because of that, we have a large differential. I did see one of our spinal cord patients. He was a younger male with paraplegic level. He developed, it really was more almost like myositis ossificans, so a large mass in his thigh that ultrasound showed initially could be blood, could be inflammatory pocket. So we have to rule out things like cellulitis and infection and abscesses, trauma, fractures, bone tumors. And his ossified, and he actually found it difficult to transfer because of how heavy his leg was. So lab tests we order right away. They're non-specific though. Serum alk-Phos can go up for other reasons. CK, in our population being a little bit younger, so the differential will be a little bit shorter perhaps for an elevated CK, so it's useful. And then ESR and CRPs, they go up for any inflammatory reason like UTI or pressure sore, so a little bit harder to use that. Because we are a little short on time, I'm going to skip over some of these medical things, which is how all these investigations change and how they're used. Go on to the imaging. So we use bone scans and ultrasounds as well as x-rays, but x-rays are most often used later, or at least they're not likely positive on the early course of the of HO. And then for CT and MRI, you definitely get definition of the bone, but we use that more for pre-op planning, not for diagnosis. Here's some information about the bone scans. So the first 2 or 3 weeks of this process will manifest on the bone scan. So it's usually one of our most commonly chosen investigations. And so we would only find positive x-rays 3 weeks after the positive bone scan. And then we can use ultrasound as well sometimes. The blood flow phase is not positive, but blood pool, start to see the uptake. And bone uptake phases of that triple phase bone scan are what we use for HO. Here's an x-ray that shows that there's already been some what's called flocculated change here in the muscle around the hip. This is a nice chart for when things present. So we have the clinical signs, swelling and fever, stiffness, CRP and CKs are up almost right away. Quickly, soon after that, by about 2 or 3 weeks, bone scan and ultrasound are positive, CT, MRI, x-rays midway through, and the alk-Phos is kind of going to stay up for quite a while. We follow these things, x-rays and some of the lab work to see how it's maturing. So in terms of prophylaxis, we don't use NSAIDs in our center, but actually anti-inflammatories have been shown to help prevent HO from developing. And then there's some other therapies here that haven't been proven to help prevent HO. And then why do we treat? Well, HO, as it forms and enlarges, can cause a lot of problems. So as you can imagine, lumpy bone where you're sitting or a change in your sitting position will lead to pressure sores. Once your joint becomes rigid or ankylosed, There'll be seating and positioning problems. You can actually provoke DVT with where the bone is if it's impinging the venous outflow. Peripheral nerves have been entrapped in the literature. Spasticity can increase from the noxious stimulus, as can AD. Patient can have pain. They can even fracture. So we've got HO. What's the treatment? First of all, we can't overlook stretching and range of motion. That's what I meant to say there. To maintain what you can of the joint mobility, so there isn't any contraindications to that. It doesn't seem to change the bone formation. In terms of modalities, we would suggest cold, if anything, not heat. Surgery is the only proven effective treatment. It says 5% of people that have problematic HO will need it, so it's not that common. I think I've seen 2 patients in 30 years or so get surgery for this. So usually the bone has to mature and stop growing, stable on X-ray. Lab work doesn't show any inflammation anymore. The surgeons want to debulk the area, but there's a high rate of complications. These patients lose a lot of blood, and then sometimes the HO recurs. Some places will use secondary prevention, so bisphosphonate regime, anti-inflammatories, radiation, and then, of course, everybody gets PT and range of motion. So we would typically on the rehab unit consider using bisphosphonates during the evolution of HO. We want to start that before radiographic HO is evident, and it supposedly inhibits the growth of HO by inhibiting the transformation of amorphous calcium phosphate into crystalline hydroxyapatite. I've not had the greatest success with it, but again, not too many patients under my care that have needed this. So in summary, we want to limit bone formation if we can and prevent secondary complications or monitor for them. Currently, there are a number of bisphosphonate regimes that people try, but they have not been confirmed with literature to be effective. Primary prevention has good literature for NSAIDs, but we don't seem to use them. It could be because the risks of NSAIDs perhaps aren't acceptable given the lowish incidence of symptomatic HO. And the reason why we believe this is important is because it is common in TBI and SCI and after hip surgery, and because we can see some typical rehab and functional implications. Okay, the goal of treatment. So we talked about this in limiting functional loss and secondary complications. So thank you very much for this opportunity to talk. And if you guys want to take a few minutes for questions, I definitely have a little bit of time.
Thank you so much, Dr. Hill, for that great presentation. I know it was speedy, but you covered a lot of ground. There was one specific question in the chat that I'll read out now, and then we'll open the floor. When prescribing compression for these clients, are they typically above or below the knee? Is there a specific strength of compression that you recommend?
So the compression alluded to in that paragraph are almost certainly TEDs, which go to the thigh, which are 8 millimeters of mercury, which don't do much for anybody unless they're in bed. And so that's my what I've been taught. So if you need compression for venous stasis or for obvious and significant swelling of the legs when they're hanging down because the patient's sitting in their wheelchair, you would move on to proper compression hose. But we're not using those for DVT prevention. So the literature on TEDs, as far as I understand it, from all populations, is that they can be somewhat helpful, but not on their own to prevent DVT in the bedridden patient. And that's why they're primarily useful in the first few weeks. I usually say anecdotally to my patients that if they're already on heparin, like the low molecular weight heparin for prophylaxis, and they're starting to move around, I kind of leave it optional to them. So if they don't want to put their TEDs on anymore, because they aren't very high pressure, and if the patient's mobile and they're in their wheelchairs, they probably aren't doing very much for anything. I just say you can stop wearing them. Does that help?
I think so.
Okay.
It's also fair to say that especially in the early stages, we would probably see everyone in TEDs for prevention of orthostatic hypotension anyway. And so they're concomitantly wearing them for 2 different reasons.
And I also move on to proper, like I would say 25 millimeters of mercury or higher compression stockings for HO. And because of ease, we'll start with knee high. If for some reason we think the patient would tolerate or need thigh high, we would go there, but I'd say most of us just prescribe the knee high for postural hypotension as well.
Thank you. Um, from a frontline perspective, like nursing therapists, what are the earliest signs of DVT and then obviously PE in SCI patients that should prompt urgent escalation?
I honestly think that if you are thinking about either of these two diagnoses, it's basically urgent because they're highly lethal. Obviously, DVT, which we usually refer to as a deep venous thrombosis in the legs, is not as concerning as PE. Um, so and then this also is something that's more acute medicine like. So I say that as soon as you notice that there's a change in swelling or the patient says, I have new swelling, you would tell your medical staff and they would check in. And I suppose if they knew the patient's legs well enough, if I saw a patient with new swelling, I would put in an order for an ultrasound. But I must say that in terms of transitioning to the choice to treat them as if they had a DVT before we have the results of the ultrasound, that takes more clinical judgment. So there might be some findings on bedside assessment that would make you more likely to perhaps start treatment before you get the ultrasound, because usually it's a day or two for ultrasound, whereas CTPE, you can usually augment that to a same day, I think. And you would try that if you have a spinal cord injured patient that is short of breath and pleuritic chest pain. Um, but in any case, the higher your clinical suspicion, which is sometimes the only thing we can rely on, which might involve like your obviously your vitals and your labs, maybe your X-ray or your blood gases, the higher your clinical suspicion, the more likely you could already start treatment if you're the medical staff, even before your tests come back, and then just stop it if it comes back negative.
Okay, I have a question from the chat about how long should we maintain DVT prophylaxis? What do we do for when they're in rehab? Should we keep it the entire time they're in rehab? And is there a reason why we stop it once they're transitioned from rehab to home?
This is difficult because some of our recommendations come from the states, and because of their funding, they would have shorter admissions. So if they say 8 weeks of discharge from rehab, it might be almost the same thing. Whereas for us, sometimes our patients are waiting for placement, so they're with us for maybe 3, 4, 5 months. Um, and so older recommendations said to continue it till 12 weeks for those with certain risk factors. Um, so actually, I tend to err on the side of discussion around stopping it at the 12-week mark, even if the patient is still in rehab. And risk factors that would be perhaps ones we would not change for patients that we would not take them off DVT would be prophylaxis would be things like underlying cancer or previous DVT or long bone fractures as part of their admission. They might stay on until the end of rehab, but that will be something that will vary between physiatrists, I think.
All right, we have time for one more question, I think. How do you balance bleeding risk versus clot risk in patients with pressure injuries, recent surgery, frequent falls, like higher risk of bleeding?
Um, Usually on prophylaxis, we don't really feel that there's really any question. Like they just need to be on prophylaxis, even if they could fall. And most of our patients, of course, could fall. Um, but if they are on treatment dose, then it could be a little bit different, but it's just so lethal to experience a PE, or have a PE, or have a DVT that could become a PE, that we generally feel the risks are worth it to put them on the treatment dose anticoagulation. If they go for surgery, there's a whole protocol for taking them off, and I'm not aware of really the standard approach for that myself, but I would definitely defer to my, hematology or anesthesia colleagues to make the right choice. Patients are operated on all the time, even though they were recently on anticoagulation. They just have a set approach to when they stop it and when they restart it. That's partly why we wouldn't want them on for longer than necessary, even though the risk doesn't really go away. It just lowers. And also, heparin is one of the causes of osteoporosis. So it has, besides even just increasing bleeding risk, there's some other issues with it that we want to limit exposure for patients longer than necessary. It is a risk balancing problem, though.